to Dr. Herd Groups 8. Our case study is over Katie, who is a 63-year-old male, 77 kilograms with a history of diabetes mellitus type 2, hypertension, and end-stage renal disease. He is dependent on hemodialysis, and he receives dialysis every Monday, Wednesday, and Friday. Over the past 6 months, he has become more fatigued overall and tires much more easily during his daily activities. Therapy was initiated with oral ferrous sulfate, 325 milligrams, 3 times daily, but Katie's symptoms have not improved. Over the last 2 weeks, his hemoglobin and hematocrit levels have been low, and he has required 2 blood transfusions, 1 each week, after the Wednesday dialysis sessions. His nephrologist is initiating erythropoietin 8,000 units subcutaneously every Wednesday. Factors are critical to consider prior to initiation of erythropoietin therapy, specifically address the hemoglobin level necessary to know about initiation of therapy. It is important to check the iron level before starting erythropoietin therapy. Oral ferrous sulfate is recommended if blood ferritin levels is less than 100 and transferrin is less than 20%. You can then proceed with caution in patients at risk for heart attack, as there is a U.S. box warning associated with this medication, as it increases the risk of death by coronary events. In coronary kidney disease, the risk is even greater when the hemoglobin is more than 11. It is recommended to use only the dose necessary to avoid the need to give blood. The use of erythropoiesis-stimulating agents has proven to decrease recovery in cancer patients and cause blood clots during the perioperative period. Second question is explain whether the sub-Q injections may be administered at home. Erythropoietin may be self-administered safely and effectively at home as long as the patient can demonstrate proper technique when administering subcutaneous injections and verbalizes understanding of preparing proper dosages. Self-administration is common in patients with renal disease. Detailed instructions on dilution and storage stability are included in the medication packages insert and should be discussed along with self-monitoring of blood pressures and education regarding when to notify a physician.
Our third question is explain whether comorbid conditions such as diabetes represent a critical factor when considering initiation of this medication. Erythropoietin is a growth factor and cytokine that governs cells' proliferation of metabolic homeostasis, vascular function, and cytoprotection. Erythropoietin can improve cardiac function, reduce fatigue, regulate cellular energy metabolism, obesity, tissue repair, and apoptosis in patients with diabetes. Katie has hypertension. Erythropoietin can increase blood pressure. Findings in clinical studies found that erythropoietin increases systemic and renal vasoconstriction. Erythropoietin can also increase the risk of blood clots, and in combination with diabetes can increase Katie's risk of stroke, DVTs, and heart attack. Therefore, Katie's comorbidities of hypertension, diabetes, and end-stage renal disease should be taken into consideration when initiating this medication. Question 4, explain the monitoring that is required for erythropoietin therapy. Specifically address when the erythropoietin therapy should be discontinued.
Erythropoiesis-stimulating agents are commonly used among hemodialysis patients to reduce anemic signs and symptoms associated with reduced kidney functions, such as fatigue, reduced exercise tolerance, dyspnea, and depression. Continuous monitoring of hemoglobin, TSAT, which is percent transfusion saturation, and serum ferritin levels are indicated in erythropoietin therapy. Hemoglobin levels are measured weekly with dialysis treatment and with erythropoietin treatment dose adjustments. Likewise, with initial ESA treatment and dose adjustments, TSAT and ferritin levels are monitored monthly and every 3 months for continuous therapy. Further, a patient's blood pressure should be monitored with continuous ESA treatments. Treatment with erythropoietin agents may increase a patient's risk of serious cardiovascular events when the hemoglobin exceeds 12 grams per deciliter. For dialysis patients, the FDA recommends that the ESA's dosing should be reduced or halted when serum hemoglobin's level reaches or exceeds 11. Specifically, higher doses of ESAs and hemoglobin level greater than 12 are associated with hypertension, which may predispose a patient for hypertensive encephalopathy and seizures. Although the medication is effective, Katie stops taking the erythropoietin due to its costs. His insurance plan prefers the use of darbepoetin. Explain how he could be transitioned over to this alternative agent.
Anemia is the complication that has the most significant impact on the quality of life in patients on hemodialysis from chronic kidney disease. Therapy with erythropoiesis-stimulating agents such as EPO and DPO significantly reduces the need for transfusions, hospital admissions, and overall mortality. Erythropoiesis-stimulating agents, or ESAs, such as epoetin alpha and darbepoetin alpha, are two of the most widely used agents to stimulate erythropoiesis in chronic kidney disease patients. In most patients, EPO is initiated at 50 units per kilogram 3 times a week, which is too low of a starting dose. However, among patients with severe or symptomatic anemia, a dose of 100 units per kilogram 3 times a week can be utilized. US FDA recommended starting dose is 50 to 100 units per kilogram 3 times a week for both IV and sub-Q administration. In contrast, darbepoetin US FDA recommended starting dose of 0.45 micrograms per kilogram every week or 0.75 micrograms every 2 weeks. Published studies on the effectiveness of EPO and DPO indicates that both agents have similar effectiveness and safety outcomes. In a study conducted in Canada comparing both agents, cost effectiveness has resulted in DPO users saved more. In converting EPO to DPO, an initial weekly dose should be estimated based on the weekly epoetin alpha dose at the time of conversion. For this particular patient, the current dose of EPO is 8,000 units sub-Q every Wednesday. Based on the dosing recommendation by the manufacturer, Mr. KD should receive the darbepoetin dose of 25 micrograms one time every 2 weeks subcutaneously, since the patient is receiving EPO one time a week on Wednesdays.
Next, I'll go over the disease process. End-stage renal disease is when the kidneys no longer function to filter the body's waste. The most widely accepted cause of ESRD is diabetes and hypertension. A target fasting glucose of 140 or less is considered appropriate for ESRD patients. It is important to control blood glucose levels so that other organs remain healthy and intact. The best choice of oral medications to control blood sugar is glipizide, due to only inactive metabolites are excreted by the kidneys. Managing hypertension with medications that regulates the renin-angiotensin system decreases diabetic neuropathy. Patients undergoing dialysis are prone to getting anemia because the kidneys are not producing an adequate amount of the hormone erythropoietin that assist in making red blood cells. Loss of blood is common while having dialysis, and additional blood draws are necessary to assess lab values. Iron levels might be decreased in hemodialysis patients due to consuming an insufficient amount of iron-rich foods, and erythropoietin uses the body's iron stores. Iron is necessary to create hemoglobin. Vitamin deficiencies of B12 and folic acid might also occur. They are also essential for red blood cell production.
Okay, I'm going to describe the drug and its mechanism of action. Erythropoietin is a stimulating agent that is mainly used for people with long-term kidney disease and anemia. Erythropoietin is naturally produced by the kidneys and is used to make red blood cells. When patients do not produce a large enough supply, the need for an erythropoietin stimulating agent is needed. The agent helps to develop erythroid precursors and increases the release of reticulocytes. Through the process of releasing reticulocytes, the erythropoietin binds to specific receptors and activates the 3 different signaling pathways. Once the pathways are activated, the protein is able to be transcribed, which enhances the making of red blood cells.
I'm going to talk about the diagnostics and management. Anemia is also known as, is defined by the World Health Organization of hemoglobin below 13 in males and postmenopausal women and below 12 in premenopausal women. However, in hemodialysis patients, the World Health Organization definition of anemia does not apply when looking at the goals of treatment. Hemodialysis patients will still be defined as anemic by World Health Organization standards, even when properly treated. The goal of treatment dialysis patients is to reduce severe anemia and avoid blood transfusions. In fact, studies have shown that chronic kidney disease patients who are treated with erythropoiesis stimulating agents to a correct hemoglobin to what is considered normal have a higher risk of adverse outcomes. Upon initiation of hemodialysis, all patients should be screened for anemia prior to initiation of therapy by obtaining a baseline CBC, reticulocyte count, serum iron, total iron binding capacity, percent transferrin saturation, serum ferritin, serum folate, and vitamin B12 levels. Testing should be repeated depending on what the baseline levels are. When the patient is noted to be anemic and requires erythropoiesis stimulating agent like erythropoietin, hemoglobin should be checked after initiating to adjust the dosage if needed, then weekly to monthly depending on the facility. Labs to monitor iron deficiency should be evaluated every month when initiating erythropoiesis stimulating agent, or when there is known or suspected blood loss. Then it should be evaluated 24 hours after blood transfusion. Treatment with the ESAs is usually indicated when hemoglobin is below 10, and depending on iron levels, the patient is usually treated with iron as well. In hemodialysis patients, ESAs lower the need for blood transfusions and improve quality of life.
The purpose and goal of treatment. The purpose of the treatment is to reduce signs and symptoms associated with anemia and improve quality of life. The goal of treatment is to effectively increase hemoglobin level and prevent severe anemia where blood transfusions are not necessary, and thereby maintaining a targeted hemoglobin level between 10 grams per deciliter to 11.5 grams per deciliter.
Points and conclusions. Prevention of severe anemia and blood transfusions is the goal for patients on hemodialysis. Baseline studies should be obtained before starting therapy and should be repeated with anemia. Hemoglobin less than 10 in hemodialysis patients is treatable with ESAs according to the World Health Organization. ESA lowers the need for blood transfusion in hemodialysis patients. Erythropoietin can increase the risk of blood clots, increasing the risk of stroke and DVTs in patients with comorbidities such as hypertension, diabetes, and end-stage renal disease. Erythropoietin can be administered sub-Q at home for proper education and return demonstration. Erythropoietin alpha and darbepoetin alpha are the most widely used ESA in CKD patients. Converting from taking EPO to DPO is possible and based on weekly dose at the time of conversion. In conclusion, erythropoietin-stimulating agents are the drug of choice to correct anemia in patients with chronic kidney disease who receive hemodialysis. Baseline labs should be obtained in these patients before dialysis and at the first sign of anemia. Guidelines for anemia are different in these patients and should be well known before starting therapy. Medication administration education with the return demonstration should be provided for patients administering injections at home. When considering changing agents, remember to base it on the current weekly dose the patient is on. Comorbidities should be well known to prevent other complications. Questions for the audience. Number 1, KD is forced to switch to darbepoetin due to his insurance preferences and high cost of erythropoietin. Are there any differences long-term in using one medication over the other? Number 2, if you or KD felt strongly about it, what would be the process be for you as a healthcare provider to negotiate with the insurance coverage to get KD coverage for erythropoietin? Thank you for listening to our presentation.